Thanks so much for having me back on campus, especially Kai and Jeff. For organizing this. It's really been nice to see how much the campus has grown and to meet many of you, and hopefully we'll get a few of you inspired to go off and do things that'll make a huge difference. So what I'm going to talk about today is some of the work that I do both in Philadelphia and in a few parts of Africa. And I'm going to start off by talking a bit about the HIV epidemic. As a pediatrician and an epidemiologist, this is the area that grabs my heart and that really keeps me busy during the day and sometimes up at night as well. And I'll talk about how I got there, because I didn't sit in a room in Augustana saying, I want to be a pediatric HIV doctor. And I don't even think I was telling the epidemiology class yesterday, I don't think I knew what epidemiology was when I was an undergrad, but it turned out to be something that really helped me to do a lot of the things that I want to do. And then I'll tell you a bit about the research that I do that helps to address some of the injustices that have become apparent to me with the work that I've done with children infected with HIV. So to start off, I want to give you this picture of the global epidemic. So what you can see here is where there's a lot of HIV and where there's less HIV in the world. So the areas that are bright red, oops, I thought that was the pointer. Sorry. There we go. Okay, this must be the point of it. Okay, so these bright red areas here are where the HIV prevalence is the highest. And you can see that they're concentrated throughout sub-Saharan Africa. Here in the United States, we see a fair amount of HIV as well. In Philadelphia, I have a clinic of about 300 children who were infected with HIV perinatally and are now growing up. That's a big clinic in the United States. In Africa, we see thousands of children in a single clinic. And I just want to highlight for you where most of my work is done in this country. Here in the middle is Botswana, and then just to the right and up a little bit is Zimbabwe. And those are the two countries I'm going to talk to you about a little bit more later. But Botswana, along with Lesotho, which is this little tiny island nation within South Africa, and Swaziland, which is kind of nestled here between South Africa and Mozambique, are three countries that had the dubious honor in around 2003 when I moved to Africa of having the highest prevalence of HIV in the world. And at that time, about a third of people in some places with a third of people overall had HIV, which is sort of unfathomable. It's like the joke about medical school where they say, look to your left, look to your right, one of you won't be here at the time of graduation. I don't think that's true anymore, so don't worry if you're planning to go to med school. But if you look to either side of you, if you didn't have HIV, probably one of your neighbors did. And yet, despite that, the stigma surrounding HIV has remained huge. And we'll talk about that a bit more later as well. And this is what the epidemic looks like for pediatrics. And you notice that I've sort of lopped off the rest of the world and just focused on Africa. And the reason for that is because more than 90% of the children who are infected with HIV worldwide live in sub-Saharan Africa. This is in contrast to the adult epidemic, where about half live in sub-Saharan Africa. There are about 3.5 million, I'm sorry I didn't update the statistic with the 2014 data, but there are about 3.5 million children who are infected with HIV throughout the world, and about 35 million adults. So even if you don't know somebody with HIV, know that it's really a big issue worldwide, and it's something where when you go to places where it's prevalent, you can't avoid, if you're not infected, at least being affected, because you know people who are infected and who are struggling with this disease. Now, we've made some progress on child deaths, and if you recall on the last slide, I had an old number that was lower than the current number in terms of the prevalence of HIV. And that's not entirely a bad thing, that the prevalence is going up, and that's because having the prevalence go up means that there are fewer people who are dying. It also means that there probably are some more people who are becoming infected. But there is a story that I told yesterday about Uganda, where they first started giving treatment to people with HIV, where people were so excited because their prevalence seemed to be going down. And this was in the news. They're saying, great news, in Uganda, there's less HIV than there was 5 years ago. And that was terrible news, and people were celebrating it, but what it meant was that the rate at which people were dying was faster than the rate at which people were becoming newly infected. And it wasn't that they were becoming newly infected at a very, very low rate. They were just dying in extraordinarily high numbers. And so what you can see here is that we've made some progress with children. So in the early decades, this is the time when I went to Africa to do work to try to accelerate pediatric treatment. There were more than 300,000 children who were dying every year of the HIV virus. We still have, and this is the most recent number, about 180,000 children who are dying every year. So we've made good progress, but we've not made the progress that we need to make. But I'm going to show you on these next few slides why I have, I think, the best job in the world. There are not very many jobs in medicine where you take people who are really, really sick on a regular basis and make them better, and you have the tools to keep them better. In a lot of specialties, you take care of really, really sick people and you comfort them as they die. And there are other things where you see people who are a little bit sick and you help them get better. Here we see kids who are devastated. You come in like this child, and then you give them antiretroviral therapy, and they look like this. I'll show you another one. Seems to be stuck. Is there a specific place I should try to point it? Try this one. But look at how much better he looks. Yeah. So this one now?
Yes.
Okay.
Right click.
Okay. Should I keep that one? So here's another picture, and if you look at this child's face, he's not just upset, he's severely malnourished. And children with HIV, even if they have access to food, often cannot maintain their weight. And being severely malnourished usually makes children very, very irritable. And so he's probably not crying because his mom just went to the next room. He's probably pretty much always like this because he feels terrible and he's really malnourished. But he got treatment as well. And all the suspense of this. Actually, I think that's a little adorable. Yeah, so I love the pictures where you can see the caregiver as well. Because imagine what it's like as a caregiver to have a child who's that sick and to expect that they're not going to survive. And then they have this sort of recovery. Let's see if I can get to that next. There we go. So there's another young girl. She was actually a teenager. So people who are infected with HIV in utero and grow up without therapy usually look a lot younger than their actual age. But we show the next picture. There is the after picture. And then the next one's my favorite. Another kid who really looks unhappy and irritable, and then he got treated, and he ends up with a problem that a lot of my patients in Philadelphia have, which is that once they're better, we have to battle obesity all the time. So the treatment makes a huge difference. This is a quote that many of us have very similar statements that we've made over time. But as a pediatrician who takes care of children with HIV, there's nothing that I would like better than to put myself out of business, to see kids not reinfected anymore. So Mike Misla is the Chief Operating Officer of the Baylor College of Medicine International Pediatric AIDS Initiative, which is the organization that gave me my start in working with pediatric HIV. And he said, we may be able to go out of business in the pediatric HIV arena, and that would make us the happiest unemployed folks in the world. This picture here is of Dearie, who is the nutritionist at the Botswana Baylor Clinic. And he is weighing a child who is not HIV infected, but whose mother is HIV infected. And we've made tremendous progress in preventing infection when we can get mothers tested and on the appropriate medications. So there's the face of prevention. But now I'm going to talk about some of the injustice. You've already seen that we have a lot of children who are dying. But what we haven't mentioned is that even though we have the ability to make children live long and healthy lives, most children aren't even getting tested. So the international recommendations, even in the lowest resource settings, are that children who are exposed to HIV should get HIV tested in the first 2 months of life. This slide says that only 39% of children in low and middle income countries are getting their HIV test in the first 2 months of life. And what that means is that when they are HIV infected, they're not accessing treatment. And unfortunately, more than 50% of babies who are born with HIV will die in the first 2 years of life without treatment. It's that devastating of a disease if we do not treat it. And we're not doing the best job with adults either. We're only capturing 64% of adults who are eligible for treatment. But among children, the number is much, much lower. This number, 34%, may even be too high. I've seen newer estimates that say it's more like 24%. So children who qualify for treatment means if they're less than 5 years of age and HIV infected, automatically they should be on treatment. And if they're older than 5, then if they have any sort of decline in their immune status or illnesses, then they also qualify. Next slide. So, in terms of injustices, we've seen great progress among adults. Between 2005 and 2012, there was a 30% decline worldwide in HIV-related deaths. And as a pediatrician, I never thought that I was really going to focus on adolescents. I like little kids. They're fun, they don't argue with you. Usually I have young kids now, they argue with me, but my patients don't argue with me very much. But I've really been pulled towards adolescents. And the reason is because that's where we're losing these patients. They start off as these really sick kids. We treat them, they become healthy. They run up to me and they say, oh, Dr. Liz, how are you? And then they become adolescents and they say, I don't want to take my medicines anymore. I just don't want to deal with this. And they have a lot of reasons that are good reasons for that. But it's resulted in extreme difficulties in keeping them alive through the adolescent years. I told you that about half of kids will die in the first 2 years of life if they're infected in utero. But the other half have this range of time during which they can remain healthy. And most of those who live through the first 2 years of life will actually live into their second decade. And it's during the beginning of the second decade, between the ages of 10 and 14, that the kids who don't know that they're HIV infected and who haven't access to care start to become very ill and die. So before he clicks the button again, what do you think has been the change in death rate between 2005 and 2012 for adolescents? Just yell out some numbers. We're a small group today.
50%.
50% decrease or increase?
Probably increase.
Increase.
20% increase.
So some good guesses. The answer is a 50% increase. So really devastating difference. And this is why, as a researcher, in addition to as a doctor, I have gravitated to this, because I gravitate to those places where there is an obvious problem and we need to figure out what the solution is. There's a disparity here. And wherever there's a disparity, we should be able to close that gap. So this slide, if you click it one more time, it'll give you a little arrow. Shows you the difference over time in AIDS-related deaths divided by age group. So this blue line here is the 0 to 4-year-olds, and this is largely due to the decrease in mother-to-child transmission. So we're not seeing a lot of new infections, and so the death rate in those little kids is going down. But the yellow line here that I've highlighted with the red arrow is those 10 to 14-year-olds. And it's more than doubled from 2000. It's an incredible, incredible increase. In young people, 20 to 24, these are not kids who are perinatally infected. These are mainly those who were infected through behaviors during their adolescence. We haven't seen a whole lot of change. And in the older adolescents, who are sort of a mix of those perinatally infected who've grown up and lived a little bit longer than the ones who peak in their deaths here, they're rising, but not as quickly as the 10 to 14s. And I just wanted to show this slide to show you that it's not new infections that's driving this. So this slide is showing you the estimated number of new infections in all of these age groups, and all of those lines are going downwards. They're all going in the right direction. But what we're not doing a good enough job at doing is finding those who are infected, getting them on treatment, and keeping them on treatment, even though we have the treatments that work. So here we're going to have to click one by one, I'm sorry about that, through all of the reasons why kids are such a challenge and why this talk landed in a social justice symposium. There are a lot of different things with pediatric care that make it harder and that make us have to work harder in order to achieve the same outcomes for kids that we see for adults. So the first one is late diagnosis. So if you don't know that someone's HIV infected, you obviously cannot get them the treatment that you need. You can just keep clicking through. So we have now 39 different drugs to treat HIV, and I'll show you in a few minutes roughly how those drugs work. But many of those drugs have never been studied in kids. And that's largely a cost issue. If you're a drug company and you're making a drug and there are 35 million adults who could benefit from this drug, you're going to try to figure out how to make it work for those 35 million adults before you try to figure out how to dose it for children of different ages whose metabolism changes over time and who need constant updates in dose, different formulations because they can't swallow big pills. And so often that just doesn't happen. One of the things that I'm not going to talk much about today is a committee that I'm on that's called the International Maternal, Pediatric, and Adolescent AIDS Trial Unit. We actually had a call this morning that Jeff helped me get on. And our goal is to try to get all of the drugs that are approved for adults approved for children as well. We're mainly funded through federal funding from the United States, and we have to prioritize which drugs do we think are going to be the most useful for children so that we can get them tested and make them available. So limited drug formulations, that goes back to the issue of if you can't swallow a pill and all that's available is a pill, then you're going to be in trouble. There are also issues of just palatability, which I think is probably the next one on there. So there may be a formulation available, but it may be almost impossible to get somebody to taste it. There's one of those drugs called Keynote. You can go ahead. I'll just keep talking while you work through it. Yes, so palatability concerns. Keynote is the drug that's recommended as part of the first-line regimen for all babies who are HIV infected worldwide. And when I'm in an audience of doctors, I would say, who's ever tasted Keynote? And if there are pediatricians in the group and they haven't tasted it, I yell at them because you have to know what you're asking your patients to do. There actually are genetic differences that we've noticed, and I'm working with a group at the Bonanno Chemical Research Center, which is in Philadelphia near where I work, and we're looking at trying to understand why some kids absolutely cannot even get near Keynote without vomiting. And I have had a few patients who like it, and when they switch to pills, they say, but I want to keep that one. Are you? What's wrong with that kid? Why does he want to keep it? But there obviously are genetic differences that we're trying to understand and why this is. But for the most part, these drugs are very difficult to take when they taste bad, as this one that's recommended for everyone does. For most people, it tastes really bad. For some, it's completely intolerable, and we might even have to put a tube in the stomach to get it into a child, which is not something we can do in a research-limited setting. That's something that we might do in Philadelphia. I did the taste study that I was setting up for parents in Philadelphia in order to understand the genetic differences. I thought, well, you know, if I'm making people do it again, I should try it myself. And I did it in the morning. It was a few hours before lunch, and I didn't even swallow this stuff. It's a swish and spit study. So you take a teaspoon of the medicine, and you swish it around, and you spit it out. And then you get water, and you swish it around, and you spit it out a few times. And it took me until after lunch to not taste this medicine. But this is what we're asking patients to do. We assume a lot of things based on adult data. So we may know that drug A is better than drug B for adults, and just assume that it's going to be the same for children. But children are not just little adults. They are very different in the way they metabolize drugs and in a lot of other ways. You know, for example, you can imagine if drug A tastes terrible, drug B tastes good, the patients might do better on drug B if they were children. So there's a need to do studies in children just to understand whether or not what's true in adults is also true for them. And then we have unique adherence challenges. So kids are never going to come and say, it's time for me to take my medicine. You need to have a responsible adult who can help them. And then you have this whole adolescent period where you have to slowly get the adolescent more and more able to do things on their own, hopefully not giving them too much freedom before they're ready for it. We also understand a lot less about what happens to children who have the virus. It's not always the same as with adults. There's some very unique things that we see in pediatrics, such as certain lung findings that are very common in kids that are never seen in adults with HIV. And the final thing that I just wanted to point out is that the psychosocial challenges are the biggest issue. And it's true both here and abroad. I only do clinic once a week in Philadelphia. The other 80% of my time is spent doing my research. And usually when I come home on Wednesdays, I'm just emotionally drained. And it's not because of the HIV, it's because, as my patients tell me, HIV isn't the hardest thing in their lives. And so sitting down and talking with patients who are telling you about their drug-abusing families and the mental health issues in their families and the dangers in their communities, it is draining, and it's something that we need to be able to address, not just as doctors, but as human beings and as people who are thinking about how to change disparities that exist in the world. So I was asked to focus a good part of this talk on just how did I get here? How did I get from Augustana to Africa and then Philadelphia and back? So the next slide is going to go through that, and then I apologize. Oh, good, I didn't make it where you have to click on it. I thought I did. I did for yesterday's talk. So I was a biology pre-med major here. But what I do want to say about my Augustana experience is that I think that what was the most valuable, other than the fact that Augustana did a great job of getting me ready to go on and go to medical school and succeed there, is the world perspective that I got here, and the fact that the liberal arts courses were not just required, but often inspiring, and made me think outside of my box and learn about what was going on beyond the Midwest and the United States. As was said in the introduction, I ended up in Texas because one of my professors here at Augie said, there's this research program at this place called Baylor College of Medicine, and maybe you should apply for that. And I did, and I went there the summer before my senior year at Augustana, and I loved it so much that I applied for early decision to Baylor College of Medicine, and that's where I went to medical school. They had a great pediatrics program, so I stayed on and did my pediatrics training at Texas Children's Hospital, and started really figuring out that I was really passionate about things that were public health oriented and that were going to not just be about the patients that I was seeing in front of me, but would kind of keep me connected to the bigger problems in society. And so I was really lucky that this job came out right as I was finishing my training with the Baylor International Pediatric AIDS Initiative. And so I worked for a year in Houston, taking care of patients with HIV. And then at the end of that year, my boss came to me. My husband was just finishing his training as well, and he's a doctor for adults. And my boss said, you know, I needed 2 doctors in Botswana where we're opening our second clinic. And I need a pediatrician and an internist. What do you think your husband would think about you guys moving to Africa for a year? And we always had talked about doing international medicine, but we thought that it's something that you do when you retire and you have free time, or maybe 2 weeks a year when you can afford to go on a trip somewhere. And so we thought, great, you know, we'll spend a year and someone will actually pay us for it. That's awesome. And so we went there for a year and we stayed for 4. And during that time, I had this just amazing, life-changing experience where I started off just being a doctor who saw lots and lots of sick kids and saw those kids that you saw in the pictures earlier, the sick kids who got better, and that was amazing by itself. But we had very little help back in those early days, and we just saw lots and lots of patients. And then I had an administrative position in the clinic, and so when patients were gone, I sat at my computer and I did all of the other stuff that had to be done. And then we got all these new doctors. And when we got all these new doctors, all of a sudden I was pulled out of the clinic into helping the government to make new guidelines for pediatric care, to help the World Health Organization do some new guidelines, to help UNICEF with some things that they were working on. And what happened with that is that I started learning all of these things that we didn't know. So for example, I sat in a guidelines meeting where I was the only pediatrician, and they made a decision that they were going to change what drug was offered for adults. And then they turned to me and they said, so Dr. Lowenthal, should we do the same thing for children? And I said, I don't know. I don't think we know that. I don't think we know if that's better for children. Let me go and check the literature and ask some experts, and I'll get back to you. And so I talked to all the experts I knew, and they talked to the experts they knew, and sure enough, nobody knew the answer to the question because nobody had studied it. And so about 3 years into our time in Botswana, my husband said, you know, I think I need to go and get more training, and if I don't do it now, I'm never going to do it. So we need to move back to the US. And at that point, he had been recruited away to the University of Pennsylvania's program in Botswana, and so was looking at the University of Pennsylvania training program for infectious diseases for his further training. And my heart was really still there in that clinic in Botswana, and so I said, well, what can I do to be with my family, but still be connected to this clinic? And so the answer was that I needed to figure out how to answer those questions that had come up that nobody knew the answer to. And so luckily at the same place where my husband was going, there was a really renowned epidemiology program, and they let me work for 1 day a week in the HIV clinic while studying to become an epidemiologist. And so I will spend the rest of the talk mostly talking to you about what I've done as an epidemiologist. But first I'm going to show you a couple of pictures. So I never recommend going on a tremendous journey alone. I was very fortunate to find a kindred spirit in my husband who also has similar passions. And that is our first daughter, Miriam, who was born in Botswana, which was an amazing place to have a young child. And that's Comfort, who helped take care of her every day. Comfort was really her name. She didn't have a Botswana name. It was Comfort, and she was a great comfort to us. And now we have another one, that's Rebecca. And they've been involved throughout this journey. I had some students asking me yesterday, how did you plan to have a family and have children and still be able to accomplish the things that you want to do? And I think the only answer is that you just have to do it, because life is not going to wait for your career, and your career is not going to wait for life. And so whatever you're doing, you have to find a balance. It's not always easy, but you can do it. So now we're going to talk about some of the research to address some of the injustices that I just highlighted for you. Go ahead to the next slide, okay? So this is the little problem that I told you about already, where I was sitting in the room and they said, should we switch to this other regimen? And I said, I don't know. And so this became my master's thesis, to look at that question. And I just love this picture. This is from a clinic in Uganda, where there's a kid trying to look up into the pharmacy. But I think it's so much more than the fact that he couldn't see. I think it's emblematic of the fact that the drugs just aren't there, and they aren't the right drugs for the kids, and sort of emblematic of the injustice that we need to serve here. So the next slide will show you a picture of what medical records often look like in the types of places where I work outside of the US. And so when I say that I was going to look at this question of which drug is better, it wasn't that easy of a thing to do, even though there were already kids on both of these drugs, and there were thousands of them on them in the places where we were trying to make this decision. But what I was able to do is to get some funding to go through records and to hire some wonderful nurses to go through and put all of the information that we needed to see who started the medicines. What were they like when they started them? How old were they? Were they males or females? How sick were they? What were their blood counts and all the things that we worry about as doctors? And which drug did they get? And how did they do on that drug? And so 5 years later, if you go to the next slide, we had an answer to the question. And now this has been incorporated into international guidelines, and we know which drug we should be giving these children, and that's more and more what is given to the children. So we got the answer scientifically, and also we were able to get groups such as the Clinton Foundation to then advocate for cost lowering, so that not only was it the better option in terms of the kids living longer and doing better, but it was also later the cost-effective option. And so I mentioned before that adolescence is the biggest threat that we have now to treatment success, and we'll talk a little bit about that. And so the issue with adolescents, there are a lot of issues with adolescents, but one of them is that the adolescents get more autonomy over what they do. And at the same time, they're often getting less support and less supervision. And there's often an imbalance between the two. And with HIV, what will often happen is that kids grow up not really knowing what they're taking medicines for. And then at some point, their families will say, okay, I think he's old enough to know, and they'll tell him. And at that point, they need the most support, because they've just learned something life-changing, and they live in a place where everybody knows what HIV is, and everybody has a negative overall view of it. And now they're associating this with themselves. But what often happens is that the parents then say, he knows now why he has to take them, so he should just do it. And so they become really hands-off at the same time that they really need to be more hands-on. So that's one of the big challenges that we face. So they have a lot of difficulty dealing with their diagnosis. They have a lot of risk behavior. So not only are they not taking their medicines, but they're often having sexual debut, often having unprotected sex. And if they're HIV infected and taking medicines off and on, what that may mean is that they're developing resistance to the medications that they have, which means that if they transmit that virus to someone else, that someone else may have a virus that can't be treated with the medications that were used for the first person. And those are the only medications in a research-limited setting that are going to be offered to them. So they may be transmitting really an untreatable virus. And so this is a time that we really, really have to care a lot about. And then peer support and peer acceptance becomes really important. And a lot of our patients will tell us, I didn't want to take my medicines because they just made me feel different. Next slide, please. So to address this, I have initiated this study that's called the Bonanno Study. Bonanno means adolescent in Botswana, which is the native language of Botswana. And it's a 5-part study that's funded through 2 different mechanisms, through the US Centers for Disease Control and the National Institutes of Health. And we're looking at a number of different things, starting off with how do you even know if the adolescent is taking their medicines or not? And the reason why this is one of my questions is because when I go back to Africa, and when I talk, which I do almost every day, with people who are working on the ground in Africa, I say, you know, tell me what is really hard for you now. Because I want to make sure that my research is making the important differences. Now, you can do science that's really cool, that answers a question that's really cool, like, why is it that some people think Kaletra tastes good? You know, and ultimately, that may become important because we may be able to choose drug regimens based on your genetics. But that's a long way off. It's a cool question. But most of the questions that I want to answer are ones that are going to make a difference, you know, not next year, then hopefully the year after. I want to approach those questions that are really accounting for the disparities in care that we see. So one of the issues is that they don't always have the biological tests that they need in order to know if someone's succeeding on their treatment or not. And so they try to see whether or not they're taking the medicines, because that's the #1 reason why people don't do well in medicines. Same thing is true here in the US. Don't take your medicines, they don't work. And it's often hard to take them. So we have a lot of ways that we see if patients are taking them. We have the biological things that are expensive, but then we ask them, and they may lie to us. And then we ask their parents, and they may lie to us too. Or they may think they're telling us the truth when they say that he took them all, but they may not really be there at the time, and they may not be aware that the kid isn't taking the medicines. We can count pills, but we know that a lot of our patients get wise to that system too. They know that when they come in with more pills than they're supposed to have left, somebody yells at them. And so they start coming in with just the number of pills they're supposed to have, so that nobody will yell at them. Well, then how do we know if they're taking their medicines? We can also look at how often they come back for their medication refills, because if they're not coming back for their refills, obviously they're not getting medicines and they're not taking them. But often with adolescents, it's the parents who come back who get the medicines, but it's the kid who has complete autonomy over whether or not he takes them. So again, not useful in that situation. So we're trying to figure out, are there subgroups of adolescents where one low-cost way of looking at it is better than the other? Other subgroups where if we only have the biological test for 1/10 of the people, that's the one who needs it because they're at the highest risk. So that's what we're looking at. We're also then meeting with the kids who are doing the best and doing the worst at taking their meds, and hearing from them about what the barriers are and what are the things that make it harder and easier for them to take the meds. And then we're looking at the ones who have discordance between the different measures. And I'm going to show you in a minute this other tool that we're using that's really cool. It's this cap that tells us every time they open the medicine. And we have the team in Botswana blinded to those data, meaning that they don't know any more than the mom who's not there at the time that the adolescent takes it, whether or not the cap was opened. But I can sit in Philadelphia in my office and say, ooh, patient 103 had 2 weeks when he didn't open his bottle. And so I can compare that to the self-report, and I can compare that to the pill count, and realize that there are differences between what we're counting and what we're being told and what's actually happening. And then we can get those kids and sit them down with an impartial person. And so we've gotten some clinical psychologists from the University of Botswana who sit down and make it clear that nothing you say is going to leave here with your name on it. And what we want to know is why these things are happening. And so they're telling us, oh yeah, I throw away my pills so they don't yell at me. And here's what it was like when they yelled at me. And here's what it might take for me to change my behavior back. So we're trying to learn how that will work. Our team also did a national survey where my team actually went out to every clinic in the public sector in Botswana, which sounds like a lot, but it's a country of 1.6 million people. So other than the fact that there's a big distance through the Kalahari Desert and those remote places in Botswana, it would be harder to go to every clinic in Philadelphia. So every clinic serving adolescents in this country of 1.6 million people, and we're asking, what are you doing to monitor adherence for adolescents, and what are you doing to help support it? And from that, once we learn what they should be doing, we're able to very quickly roll that into policy with the help of the Ministry of Health. And then the longer study, which is now in the third 5 years, is looking at the ways that adolescents change over time in terms of their behavior and how that impacts their adherence. So next slide, please. So this is the fancy cap that I was telling you about. So their medicines go in this bottle here. So this white thing is the medicine bottle, and then this cap on top then goes and sits on what's called a MEMS reader. And the MEMS reader then gives us this information, which you can see better on the next slide, which tells us every time they open their bottle. So each of these little dots is a time when the patient opened the bottle. So you can see that this patient takes the medicines at 6 a.m. and 6 p.m. And really does a great job most of the time. But the gray lines are when they miss a dose. So there's a missed dose, and here we have a line for the whole day. That's the whole day's missed dose. So no dose for both 12-hour periods. And so from this, we can get all sorts of information about what's going on. And we also ask the patients when they come in, what happened between this visit and the visit before? Did you have a wedding or a funeral, or were you hospitalized? And we're able to put all of that information together. Next slide, please. So this is how the medicine works. I'm not going to go through the mechanisms in detail, but we have a number of different drugs that attack a number of different stages in the way the virus makes more of itself. So the virus comes into the human cell. It gets incorporated into our own DNA, which is why we don't yet have a cure for this disease, because it actually becomes a part of the person, and it's very hard to take that part out without killing the parts that we don't want to kill. And then it makes more of itself and puts the HIV into the area around the cells of the body. And so what we measure to see how well patients are doing is what we call the viral load. So before treatment, it's very high. We can be millions of copies of HIV in just a milliliter of blood. And our goal is to get it to be undetectable, where we can't even see it within the blood. And usually we're able to achieve that. Next slide, please. So I talked about these low-cost measures already. Move on to the next slide. And so now I'm going to tell you a little bit about what we're doing in Zimbabwe now. Everything else I've talked about has been in Botswana, but I realized that I needed to find another country, which was a good thing. And the reason for that is because Botswana has done a really great job at finding its HIV-infected patients and getting them on treatment. It's a country of 1.6 million that used to be low resource, now is considered moderate resource because it has a lot of diamond wealth. And the country has been very responsible and has taken that diamond wealth and invested it into the healthcare system and the education system. And so there are not thousands and thousands of untested adolescents in Botswana, but in almost every other high prevalence country from those maps that I showed you earlier, there are. And Zimbabwe is one of those countries. So next slide, please. So, unfortunately, an adolescent can't just say, you know what, I'm going to get an HIV test because I've been sick and I think maybe I need one. They need to get someone to consent for them. And there are a lot of reasons why parents don't want to do this, or extended family caregivers don't want to do this. They're afraid that the family will be stigmatized if indeed this child, whose mother and father died of HIV, also ends up testing positive. And so stigma is the major barrier to whether or not individuals test. Next slide, please. So I partnered with an organization called Africaid, which has a group called Dearie, which is that funny word spelled with a Z, down there. And Dearie means as I am in Shona. And they named it that because at their very first support group meeting, which was almost exactly 10 years ago, a 14-year-old girl said, what I really want from this group is I am a young girl with HIV and I want people to accept me as I am. And so they named their organization As I Am, which is Dearie. And they now have support groups, and they have what are called community adolescent treatment supporters, who are HIV-infected adolescents who go out and help support newly diagnosed and struggling adolescents to take their medicines well. But one of the girls in the group said, most people say that when times are hard, wait for the storm to pass. But Dearie has taught me to dance in the storm. And it's my belief, having worked in HIV now for 10 or 15 years, that this is the attitude that we need to perpetuate. We need to get people to say, it doesn't matter that I have HIV. Look at me dance. And get people to realize that there's no difference between me and my neighbor who does not have the virus. Next slide, please. And so this is going to show you a video, which is part of the newest project that we're trying to get funded in order to get people to test. So I think you're going to have to click on the bottom. You don't want to go to the next slide, but we had it to play before. There's a strip there on the bottom. I promise it worked in this very, very So while I'm trying to do that, I'll tell you a little bit more about the story. So Dearie put together these 30-second video clips, and they had no idea what they were going to do with them. They said, all right.
Or new parents for you to take us for HIV testing. To you parents, we would like to encourage you about taking your children for HIV testing, because we children depend on you parents for you to take us for HIV testing. It is also good for us children to know our HIV status.
So Dearie made these videos. Go on to the next slide, because they felt like this was a message that they needed to get out there. And they made not only videos that were children speaking, but they had nurses, they had parents, they had ministers. I'll show you a minister in a minute and the message that he gave. But they didn't know what they were going to do with them. They just said, we feel like we need to get this out somehow. And at the same time, a call came out with proposals to try to increase HIV testing for adolescents in resource-limited settings. And I was sitting down with the director of Dearie at dinner in Zimbabwe, and she was talking about these videos, and I said, well, what about if we got this new group of cats? So the cats are their community adolescent treatment supporters who go out and support the kids who are already on treatment. And I said, we could call them testing cats, and they can go out, and they can show the videos, and they can tell their inspiring stories, and they can make sure that people know that you can be 10 years old and have been born with HIV and still look healthy, but not for long if you don't get tested. And what if we look and we see if it makes a difference? If we do that in 16 communities, and 16 communities don't do that and just offer testing, will the stigma reduction make a difference? And so that's what we're hoping will be our next project, and we're hoping that this will really make a difference in getting kids to test before they're sick. So this is the minister and what he felt was important to say about it.
It is critically important that both young and old within our churches must go for HIV testing. For the scriptures tell us in Hosea chapter 4 verse 6 that my people are perishing for the lack of knowledge. It is therefore important that parents must take their children for HIV testing.
So, maybe not quite as well as the documentaries, but we are hoping that this will make a difference in that yellow line that we looked at earlier that is showing a huge disparity in death rates. We'll go on to the next slide. The next slide just shows a house. And I actually stole this from a friend on my way here because she had just posted this. This is from Kenya. And I have a friend there who does very much the same thing that I do. And she had just come back from visiting this house where a grandmother lives with 14 children who she's taking care of. And 2 of those children are my friend's patients who had not come back for care for a while. And so they went out there to see why they hadn't come back and what they could do about it. And the issue was just that the household was overwhelmed and that couldn't be a priority at that point. And so I want to point out too that the disparities that we're seeing, the lack of justice a lot of it is because of questions that we can answer as scientists, as people who are working in the field. But there are other things that are much bigger than that. And unless we also address the poverty and the inequalities in the world, a lot of epidemics are going to continue to perpetuate. And I want to end another slide for that, but this is one of my favorite slides. I usually end with this one. I guess I'm going to end a little sadder today. This is a slide from Botswana that shows kids at camp. And half of these adolescents have HIV and half of them don't. And I love this picture because you can't tell who are the ones with HIV and who are the ones who aren't. So this is always our goal, is to have people with HIV really live life and see themselves and be no different than people without HIV. Oh, I guess my other slides are open. This is my team. So there are many, many people working on these projects. The other slides that maybe you can go back to. Oops, my kids again. You go back to being not on the slideshow. There are a couple of slides about Philadelphia, and I just wanted to show them as well. Oh, you know what? This is the wrong version. Okay, I'm going to tell you about Philadelphia for a second. I'm sorry the slides seem to have disappeared. I think this is an older version. In Philadelphia, my patients have access not just to 1 or 2 lines of treatment. They can fail in their treatment and have more and more choices for quite a while. But unfortunately, many of them tell me that HIV is not something that they feel like they have to worry about. It's the violence in their neighborhoods. It's the fact that they can graduate high school without being able to read. And so I had pictures of people picketing in Philadelphia because our school systems are so underfunded that they're closing schools. I live 7 miles from where I work in inner city West Philadelphia, and my kids go to wonderful schools that are public schools. But you cross over the city line, and it's an embarrassment. And we advocate for our individual patients. We do testing for where they are academically, because HIV can affect your brain as well. And we go to the schools and we say, this individual is in 11th grade, but he's reading on 4th grade level, we need to get additional supports. And they say to us, oh, she's average for our school. And here we are saying, this is a person with a disease who needs extra help, and the school systems are telling us that they, as a school system, are diseased. In a way that I, as a doctor, and thus far as a researcher, haven't been able to touch. So I just wanted to point that out as well, because while I spend most of my days thinking about these thousands of kids in Botswana and Zimbabwe and millions throughout Africa, we also need to think about the kids in Philadelphia who are not my patients, who don't have somebody calling the school, who are really very, very disadvantaged. And I had one other slide that showed a red ribbon beside a blue ribbon. The red ribbon, as most of you probably know, is the ribbon for AIDS awareness. The blue ribbon is the ribbon that was chosen to be displayed at the funeral of one of my patients who was murdered. And I've not lost a patient to HIV in Philadelphia in the last few years, but I've had a patient shot in the head because she got in the crossfire, and another patient who survived another gun attack. So, we have to keep those things in mind as well. I've gone where my heart led me to work mainly on HIV, but the problems that these patients with HIV who live in the US face often have very little to do with their disease and very much to do with the inequalities in society. So, sorry to end on that sad note, but I think that was supposed to come before this picture right here.
Dr. Lowenthal.
I was going to ask, what are the primary sources of HIV for your patients?
Primary sources meaning?
How do they acquire HIV usually? Is it through mothers, or do they contract it themselves?
So for my patients, it's mainly mother-to-child transmission. At Children's Hospital of Philadelphia, we actually have 2 different pediatric HIV clinics. The one where I work is specifically for the perinatally infected kids, and then the adolescent clinic, which deals with adolescents with all sorts of issues, takes on the ones who are behaviorally infected, because often they have different needs than at least the younger kids who are perinatally infected. In Africa, most of the kids between 0 and 14 are perinatally infected as well, although there are some isolated epidemics that are due more to abuse.
Additional questions?
Heidi?
Where do you obtain most of your funding for things like research and medications that you're able to dispense? Who funds that?
Yeah, so the question was, where does funding come from? And the answer is wherever we can get it. But for the medications, there are a number of large international organizations that help fund research-limited settings. There's PEPFAR, which is our domestic program, that stands for the President's Emergency Plan for AIDS Research. It was initiated under George W. Bush and has grown since then, which provides a lot of funding for medications as well as technical support in a number of our big countries. And then other international groups such as the World Bank contribute, and then individual countries' governments have to help as well. And there are other NGOs such as the Clinton Foundation that do work to try to lower costs and to work with drug companies to get drugs available in those settings. The research is usually funded through very different mechanisms. We do have federal government mechanisms to fund research as well. They're usually most interested in scientific questions as opposed to the public health questions, and so I always have to find a balance depending on who the funder is and make sure that what I'm doing is important on the ground and of interest to the funder. That's going to make us smarter as a people. And then sometimes drug companies will fund individual investigator ideas and foundations as well. I spend a lot of time reading grants.
All right, time for one more question, and then I'm sure Dr. Lowenthal will stay behind a little bit if they have additional
Yes,
questions.
absolutely.
Actually, I could probably ask, Elizabeth, are there opportunities for undergraduates to get involved in this through internships or other experiences throughout Africa, or?
So the question was, are there opportunities for undergrads? And the answer is absolutely. They are competitive, but there are a number of opportunities. At the Children's Hospital of Philadelphia, we have something called the CRISP program. I can't remember what it stands for, but it's CRISSP. And the application deadline, I believe, is February 2nd, if anyone's interested for this summer. But the hospital funds undergrads to come to Philadelphia in order to do research. And so I will have one undergrad through that program and then probably one through the University of Pennsylvania as well, which I'm not sure if that may be restricted to UPenn students, UPenn undergrads. But the CRISP program, I've never had a Penn student. I've always had outside people. So they're just looking for smart, motivated people, and they pay you a stipend, and you just have to apply and then interview and get one of the slots. So that would be a US-based position, working with data on these projects, Skyping with the folks in Africa and talking with them that way. For Africa-based positions, those usually require much longer commitment. And the reason for that is because it takes a lot of resources on the ground to integrate anybody to do anything that's going to be useful. And we found that unless there's a prolonged commitment, usually at least 6 months, but they prefer at least a year, that it takes more from them than it gives to them to have somebody committed to help. So we can make use of people in Philly in a summer's time, but to make sure that we're not burdening our African colleagues, we really can only have long-term people over there.
All right, well, join me one more time for